Good evening, everyone. Today, as Madam has said that we are starting a new round of case discussion, slightly different than what it was earlier. We are going to use more of a reflection entity to the cases that we have seen. In the last 5 to 6 months, the cases that we have presented, most of the cases that we have presented are the ones that we have done well, those cases which has gone well and done well. Here, now we will present some of those cases where things were challenging. I'm not telling that they were not done well or not been successful, but had been more challenging. And as we reflect on these cases, we need to see what are those learnings from these cases and how we can apply those learnings to a next case that comes into a practice. And usually, most of these difficult cases teach us a lot than the actual good cases that has happened. So today is the first case in the series of our presentation. So I will use a blend of case, a little bit about the reflective practice and reflection, and then come back to the case. So it would be this blend of a case, a little bit about the reflection, and then back to the case. This is just so that to orient the future participants who will be doing a similar kind of presentation. So I'll start with the case. So this is an 82-year-old male. Now this case is almost 13 years old case, but this case is still imprinted in my mind because of the impact that it has created. So those who were part of this case are definitely not there with me right now, but it has created a lot of impact. So that's why I decided to present this case among many other cases that I had uh, had a bad experience. So this is an 82-year-old man whose wife had died many years ago, and he lived with a female companion, and he lived at his own home. He was very independent. He was a fiercely independent man. He used to swim, garden, do his own shopping. He was quite cognitively sound. So he had transitional cell carcinoma of the bladder. Twice transurethral resection of the bladder tumor was done, and palliative radiotherapy was done. The main issue that was there was he used to get recurrent urinary tract infection, and he had intractable pain in the penis and in the groin area, which was a combination of mixed nociceptive neuropathic, and he had severe pain over the hypogastrium, which was due to the bladder colic, and he always reported this pain as 10 by 10 pain, and he was referred from oncology, from radiation oncology, to palliative care for symptom management. Now, when we saw him, he had borderline renal functions, and he was on morphine initially for a pain as a pain medication, but would not tolerate morphine. He had severe vomiting with morphine, so he was changed to other medications, and a host of other medications were tried. And with almost 125 microgram per hour of fentanyl, 2,700 milligram of gabapentin, with 2 grams of lignocaine and 500 mg of ketamine, uh, he had only 30% pain relief, and he was also on oxybutynin, 10 milligrams per day. All this cocktail of medication only gave him 10%, so 30% of relief. So this guy was decided to be put on an intrathecal pump. So an intrathecal was placed with bupivacaine and fentanyl going via Walkmud infuser port. because he had recurrent UTIs, he was put on IV antibiotics. Um, and initially, when we put the intrathecal with bupivacaine and fentanyl, he had an excellent relief. But 4 days later, after the intrathecal was put, he had pericatheter CSF leak. And initially, compression bandages were tried, which did not give any relief. And twice, an epidural blood patches was done to seal the leak. And later on, he went on to develop pharmacological paraparesis because his bupivacaine dose went up for his pain management. And from a fiercely independent man who used to do everything, he suddenly became a wheelchair-bound patient. So 2 weeks later, although he was wheelchair bound, he had some relief. But 2 weeks later, he developed an infection at the intrathecal catheter site. It was went on to become a meningitis. He needed hospitalization, 2 weeks of antibiotics, recovered, and the intrathecal had to be removed. So at that point of time, the surgical opinion was taken, and they decided that the best thing to do is to remove the bladder and do an ileal condit, and maybe that will solve the problem. And it actually did solve the problem for a period of 6 months, where he had a pain-free interval for around 6 months. Within 6 months, he had the recurrence of tumor at the same site, at the same bladder where the site was. He had recurrence of tumor, and he developed again the same intensity of intractable pain, which again did not respond to oral opioids, transdermals, and adjuvants, etc. And he again needed an intrathecal catheter because the pain was so severe. And again, second time, uh, the second episode of intrathecal also, he developed CSF leak. Again, he had an intrathecal cytic, and he needed multiple hospitalization, either for a pain crisis or for an infection, which was either an infection related to intrathecal site or an urinary infection. Even the conduit site, he developed infection. And finally, he died due to CSF sepsis. So this whole case, probably which I presented in maybe 5 minutes time, happened over an year, but which is a very compressed version that I have provided here. So it was a very challenging case with regards to pain management, and this challenge was not just felt by me, but also by my entire team. So, what is a reflection? Because we are all talking about case reflection. So, reflection is nothing but is that you look back at the experience. Now, as I told, this is a 13-year-old case that I've seen, and I am looking back at this experience, and there is definitely some learning through this experience. And it is not that one case that you look back and learn from this experience. We probably, all of us, as the years of practice goes on and on, we have hundreds of cases that what we see, we learn from those experiences. This experience becomes endless. So, what is the purpose of having a case reflection or reflecting on your practice? Is always we have our own vision of what our practice should be and what we should be doing and what our actual practice is. So there is this gap between what is our vision of what a good practice or an ideal practice or the best practice or what we call good practice is there, and there is what we are actually doing. And the purpose of this reflection is to bridge that gap from what we actually want to achieve to what actually we are doing. So this gap being bridged, and this gap you will not be able to bridge with one case or two cases. It's an overall cumulative effort. That's why we call it endless experience. That's why we keep learning. I may be 15 years into palliative care practice, Dr. Sushma Bhatnagar may be 30 years, or Dr. Cynthia may be more than that. But every day we are learning from these experiences. That's why it's called as an endless experience. and we constantly course correct us to realize our vision of practice. So that is what we call it as a reflection. So there are many layers into the reflection that what we do. The what we are doing today, or what the CTC they are asking you to do, or the next few months, where everybody is presenting their own case, is point number one: reflection on experience. That means that it has already happened, the event has already happened, or the case has already happened, and you look back upon the case or on the experience and reflect back on that. So that is considered as the level one, or the first step. The purpose of attending all these CTC reflections, reflective presentation, is to become level 4, which would probably take you ages. But over a period of time, rather than you start reflecting on an experience, that means the entire event has happened and you look back on that event and you try to learn from that event. You next step, that is what is called as reflection in action. That means you are going to plan for uh, a procedure, and before you do the procedure you start reflecting. Do you think that the procedure is the right thing for the patient? Does that procedure will give benefit for the patient? What is the benefit, what is the burden, what is the meaning of doing that procedure? That is what we call reflection in action. The third thing is reflection within the moment, every step, even within when you're doing the procedure, you are constantly reflecting. And the last thing that what we want to achieve is a mindful practice. So that is what we call like a transcendence. You become a mindful practitioner, which is the highest level. But I think it's a good starting point with number one is to start reflecting on our experience. Slowly, we will start building up on reflection in action within the moment, and then you become more mindful practitioner. So it is that to bring about that self-awareness with an intent to realize a vision of practice. So as I told, there is our vision of practice, then our actual practice. Then there is a gap which we are trying to bridge. And it is to continuously look at the big picture and to do what is in the best interest of the patient. So there are different frameworks to do understand reflection. This is one of the interesting framework that I thought was useful, called as the Carper's fundamental pattern of thinking, which has three things. One is looking back, reviewing the self-development, which influences our future practice. So when we review our self-development, we look at four things. One is the ethical, empirical, personal, and aesthetic. So what each one of means? Empiric means evidence. Suppose you want to plan a procedure or an intervention. What is the evidence for doing that in the current literature? Is it a scientific thing, or you want to prescribe a drug? What is the evidence of that? So that is what we call it as an empiric framework. The second thing is the ethical framework. So when you talk about ethical, is that we look at what are the ethical principles guiding that. So we talk about beneficence, non-maleficence, autonomy, all those things. So suppose when you're doing intervention, does it do good for the patient? What does it cause harm for the patient? What is the ratio of good versus harm? That's the ethical principle. When you talk about personal way, it is about what does the patient wants, what does the family want, what are their preferences, what are their goals, are we considering all of them? And aesthetic is what is the bigger picture, what is the broader meaning of doing all these things. So this is your reflection in action, or reflection in moment, where you're continuously thinking all these things when you are doing. So this is one way of looking at the reflective practice. The the other thing, what they call it as, what is called as an activation trinity, which they call head, heart, and hand. So that means what you're thinking, what you're feeling, and how you're responding, all should be congruent, isn't it? So many times We do things that we feel that may not be the right thing. I'll give simple examples like resuscitating a patient in an advanced or critical illness. A lot of time, what happens is that when we do this resuscitation, so many times the consultants will say, "I really felt that we should not be doing, but we had to do that." So that is very important. The process that is involved is, uh, are we committed in being reflective? So if we are committed in being reflective, there is this constant strive to become better, and whether we are ready to consider new possibilities. And we always live in a very contradiction, like there would be so many negative feelings for the situation, there would be a lot of tensions, but within that we need to follow the process, and our purpose is to become better and to empower. So the following the reflective process is very useful in a long run. So, why reflection? So, what is the difference between the practice and reflective practice? So, the practice is more of a linear thinking. So, reflective practice is iterative thinking. So, what do we mean by linear thinking? So, linear thinking means that A leads to B, or B leads to C. Following up on an investigation and acting upon an investigation is more of linear thinking. Iterative thinking is to constantly going and coming from the front and back. A reflection within just a practice where you see multiple parts, but we fail to see the whole thing. Whereas in reflective practice, we look at the more of the holistic thing. And in a regular practice, we look at lot of application of knowledge to reflective practice, where we look at the wisdom. So it's very important to look at the reflection as a practice. So this is what the method that I am following for my case study, which Dr. Seema also has provided a framework as for PPT, which also is based on the what is called as a Gibbs reflective cycle. So Gibbs reflective cycle has 6 parts. So first one is description. So description is what happened. Feelings is what were you thinking and feeling when that happened. Evaluation, was the experience good experience or bad experience? Analysis, what sense you make of the situation? Conclusion, what else you could have done? And action plan, if the situation comes again, what would you do? So these are the 6 cycle, 6 parts of the what we call Gibbs reflective cycle, and this is a good framework for any case that could be discussed through the next CTC cases. So the first part is what happened. So I've described what happened. So I gave you a detailed description of the case and explained to you what happened. The second part is what were you thinking and feeling? So many thoughts crossed across my mind. A feeling of helplessness, because after doing all these things over a period of 12 months, you did not have the ability to mitigate the pain and suffering. So definitely the feeling of helplessness, feeling of inadequacy. You always feel that whether you did not have the adequate skills to manage the situation. Always there is a feeling of self doubt. Am I doing the right thing? Was there some other approach would have been a better approach? Did I go down the path which was not the right path? Then slowly this avoidance sets in, because it's very difficult to face your own failures. And sometimes when the patient comes for follow-up, you will always say to your colleague, you go and see the patient, or you will be happy to transfer them from one service to another service. And you are always constantly pressurized by the family the nurses or your own residents asking, he is in pain, what else we can do? So you don't know have the answer for that. So this is the feelings of the reflective cycle. Part three, that is evaluation. Was the experience good or bad? For me, this experience was a bad experience. That's why, see, bad experiences remain in your mind for a much longer time than the good experiences. If you ask me in one summary, how did it go? I felt nothing went well. We made 12 months of his patient's life miserable because we did one procedure after another procedure because there was not a good time that we had given. Yeah. And we made the treatment of the symptom probably more grievous than the symptom itself. And as I said, we kept pushing him from one intervention to another intervention. What sense you make of the situation? I think looking back, I think we should have taken pauses. We should have taken a step back at each, looked at each step, discuss the goals of care rather than offering interventions after intervention. Know what the patient's wishes were. We should have communicated better, and we were blindly taking the advices whatever the chronic pain services had offered. And sometimes maybe they did offer good advice and they did help us a lot, but maybe we should have been more balanced while we are acting upon those advices. What else you could have done? I still don't know what we could have done differently, short of palliative sedation. What else could have been done differently is still an enigma for me. If this situation comes again, what would you do? I would definitely communicate better than what we communicated in this case. Elicit preferences and goals. And most important thing would be to discuss the limitation of available intervention. What is the meaning of doing one intervention versus not doing an intervention? The benefit of doing, and what would be the quality of life impact of those intervention, and also the meaning of the total bigger picture of doing an intervention or not intervention. So this was the six parts of the Gibbs reflective cycle, which I feel is very useful, which I've used in many of my practice, not just for this case but for other cases. Is to first to know the description is what happened, next to know the feelings, what were we thinking and feeling when this happened. Third thing is evaluation, was the experience good or a bad experience. Fourth is analysis, what sense you make of this situation. The fifth one is conclusion, what else you could have done. And the sixth part is action plan, if the situation comes again, what would you do? So I think this is an essential part of it. So I would just close this session with one quote, and I want people to read this and reflect on this. And then after that, for next 30 minutes, we could have discussion on this case, or we can have discussion on case reflection, or are there any other ways of reflecting? So this is I'm not going to read this, and after you're finished reading, I would stop sharing, and then we'll go in for the discussion. So I assume that people have uh, read this. So I'll stop sharing, and this is just a sample case that I have given, and I would ask others to contribute and take the discussion forward. Can I ask Dr. Cynthia to start?
Thank you, Naveen. Thank you for presenting a case that makes us feel very uncomfortable. as it was meant to do. It is not a case of success. It is not a case of which is straightforward. But I also don't think that it's a complete case of failure either, because there were sort of surprising twists and turns during this case, which I really didn't expect. There were a lot of things that I wanted clarified. For example, when you did the intrathecal catheter insertion, was it a tunneled intrathecal? And, why did it leak? Is it common for intrathecal catheters to leak? And for this man, not just once, the first time, the second time it also leaked, which, I find unusual and maybe difficult to understand. And then the real surprising twist was the cystectomy, the total cystectomy. I didn't expect that was going to be used for pain management. I have heard such things, but and it gave him 6 months of relief. So, does that mean it worked? I think it did work for 6 months. It didn't completely solve the problem. But it was there. But it was, a surprising twist to the story, which I hadn't expected. And then later on, the local recurrence, which was, I suppose, expected. And then sort of when you reflect on what else could we have done, here is a very active man. He wants to remain active, and yet, he had to have such a high intrathecal infusion. Presumably, it was the bupivacaine which paralyzed him, and he ended up in a wheelchair. What else could we have done? I suppose I would draw on my own experience to say, I've also seen cases not exactly like this, but similar to this. And what have I seen worked? So one of the first things I wanted to ask, I mean, you gave us a very nice picture of this 82-year-old man, vigorous, full of life, independent. And then he was stricken with this intractable pain. I think the first thing about the pain was that you didn't really expect an opioid to work on him, with pain which is intermittent, extremely severe at one end of the range, and perhaps non-existent in between. You don't really expect an opioid to work. And I presume you didn't struggle very long with an opioid before you turned to the intervention. Perhaps I want to stop there and let either others take up this, or perhaps Naveen, you'd like to address some of these?
No, there are many intervention physicians in this group, and I would like their views. As I said, this case was my very long time back, uh, and this was in 2006, 7, 13 to 14 years back, just at the end of my training period. Things probably have changed a lot, even in pain management and intervention. But more focus rather than the intervention, it was the impact that it had us on me and also on the team, because I was his primary physician almost.
So were you the person in charge of this patient?
Yes,
or you
yes,
were a registrar
yes,
at that time?
yes. Yeah, I was a registrar, but I was in charge of this case for 12, almost the entire duration of the case. Although my consultants intermittently used to come, every day I would see the patient, then talk to the family, liaise with the chronic pain unit, and do every bit of thing, including doing home visits whenever he got discharged and went home. So I was very closely associated with that. I had seen him when he had started to come to the end, what has happened. And it was a huge, huge shift from where it started and where it ended, and within the period of 12 months. And that surgery did give him some time of pain-free interval, but it did not actually improve his overall quality of life. He had a lot of morbidity related to the surgery per se. It's something, there is an ileal condit and his bladder was removed, and it's a very morbid surgery per se. Yeah. Yeah.
And was he able to walk, for example, after the surgery?
He was able to walk, but he was never back to his original life where he started. So
Yes.
that's the challenge. Yeah.
So some of
So
the questions that you'd be asking is, would you have discussed with him the implications of the surgery a little bit more?
right,
And maybe he might not have gone for the surgery
yeah,
if he understood it a little bit better.
right. Sushma madam.
Naveen, before I speak, I think anybody wants to comment. Anybody else wants to comment?
Mahesh is there. He's in.
Mahesh, Mahesh, please. Anyone, please put in the chat box that I want to reflect what
Yeah,
Dr. Naveen is.
Raghavendra is there. Two interventional.
Okay, please, Raghavendra and Mayank.
Saurabh Joshi is there. So many people are there. They can give their gifts. Yeah,
Okay, please speak. So start with Saurabh.
yeah, Mahesh.
Mahesh?
Mahesh. Okay, Mahesh.
Hi, good evening. I, I, I heard the case. I joined a little late, but from what I've understood, that this patient had interventions which did not work. One of the things that I keep telling our fellows is that chronic pain management starts after a failed intervention, because normally a lot of people who train in pain management are taught that interventions are the apex of what we do. But having interacted with palliative care professionals and having seen that it's not the so I keep telling my patients that you may be pain free but you still might not be happy. And I was just handling a patient who was on extremely high dose of morphine 3 days ago with chest pain. It wasn't recovering with anything. And when we did a PET CT scan and when we found out that he has a malignant rib fracture, and when we told him that it's a rib fracture, his pain went away. So I when I reflect on these, I think it's a very unenviable position. I don't think I can actually comment on it. Yes, but our interventions fail, and I think it's also about how we communicate as specialists with our colleagues and with the patient. That we don't we don't tell our patients the percentage of our procedures not working. We talk to them about when we sell it. We talk about the good part. We usually don't communicate that there is a possibility it may not work. There is a possibility there'll be complications. But this patient to have two intrathecal catheters leak is, as I agree, it's a rare thing. Unfortunate, but it's happened. That's all I like.
Raghavendra.
Dr. Mayank Gupta is also there. It's another intervention.
Okay, Mayank.
Hello.
Yeah.
I think, um, sir, I think any intervention none of the interventions are totally 100% proof saying that it'll work 100%. And intervention cannot be just physical interventions. It could be any other intervention, as rightly put across by you, sir. And I feel interventions can fail at any point of time. Intrathecal catheters could migrate, they could have infection, they could have other things. And we need to actually have a discussion, as Mahesh put across a very unique word. You sell your intervention. So if you don't want to sell your intervention, you don't want to sell it. That's it. And you would stand on that point and reflect on whatever your practice is about, giving the right approach to an intervention. And you can't act as God. You can act as a person who knows a little bit better than that, rather than saying that I'll be able to eliminate your pain. I think my approach to intervention is I would never ever promise to anybody who would come in my to OPD to saying that I will do a magic intervention and it will eliminate your pain, is something we never approach of mine. I think we will have to take it with a pinch of salt, or after we practice palliation for a period of time, we take it with a bag of salt. So I feel interventions are important. Interventions do have a role, but we can't actually oversell it. I think we will have to actually put out the right thing. And in your case, it's very difficult, sir. It's impossible unless and until you have not gone through this episode. you will not be able to actually recollect and put across, saying that this is an experience, and no book reading, no amount of any of the other textbookish work will be able to actually teach. I think reflective practice is the best way ahead. I think so. Thank you.
Anyone?
Mayank?
Anyone wants to? मयंक नहीं बोलना चाहता तो कोई और बोलना चाहता है, बताना चाहता है क्या सीखा आज?
No, ma'am, nothing much, ma'am.
Saurabh wants to speak.
Who said
Go
nothing
Go
much?
ahead, Saurabh.
Seema.
Nothing much.
May I?
Nothing much to say, or you have not learned anything?
May I?
Yes, please.
Who is that?
May. Dr. Lalit.
Lalit. Yes, sir.
Yes,
Yes,
please.
please, Lalit. Yeah.
Dr. Naveen sir, the today lesson is, as Dr. Mayank has mentioned, we have to offer but not promise. Maybe some failure may be there. And one more thing, that every discussion with colleagues as well as our experience, if we are sharing, we can came across the cases and we can able to give inputs for the patient benefits.
Very good, Lalit. Anybody wants to share anything?
Ma'am,
We have time.
I want to ask something.
Yes.
Bolo.
Acha, we have talked about interventions, we have talked about other issues also, but what has been consistent in this case is that the deterioration has been progressive, and the failure of, failure on our part to give relief has been progressively coming up. So, and with successively failing one by one in all the pharmacological management, then interventional management, it becomes really difficult to handle the situation, and we really start avoiding, as sir has just discussed in one of these slides. So I would actually like to understand how you dealt with the situation, because you stuck with the patient and you kept on giving care to him. You also went for home visits. Definitely family would have complained a lot about a progressive lack of relief, and they must have their own issues, they must have their own complaints as well. So how did you handle that? That is something which is really important for all of us to learn, because as soon as we start failing, we start avoiding.
Yeah, it was a very challenging year. I think what kept the case together was that they probably found me talking to them every day. Like, the consultant rounds used to happen twice a week, and it's very brief rounds. So you are actually there as a registrar, speaking to them every day. And I think I kept utmost honesty with what's happening, and I explained, because there were series of complications like the CSF leak, you put compression bandage. Like, I am not an expert in managing a CSF leak, so I had to call the chronic pain. So chronic pain will come, they will do the epidural blood patch, and they're out of it. And probably they at least bother to communicate, because you call them to put the intrathecal catheter, they put the catheter and gave you the pump. So Dr. Cynthia asked why it was not tunneled. The practice then was that they would put the catheter and they would wait for at least for a week to see how they're tolerating intrathecal. And if they were tolerating intrathecal, so they used to put a Walkmed pump and to see if they're tolerating intrathecal without any complications and is giving relief, they used to take it up for the tunneling procedure. So that was how they practice. So that's why it was not tunneled in the beginning. Maybe it was tunneled in the beginning, the infection risk would have been substantially less. Yeah. So that's one point. So second point is that that person's face is still in front of me because he was in excruciating pain. It was like whatever that you tried, like 2 grams of lignocaine was going on, 500 mg of ketamine was going on, loads of fentanyl infusion, opioids, everything. Nothing was helping. Uh, Intrathecal was the only thing that at least gives some relief. And the doses had to go up so much that there was a paraparesis set in because of bupivacaine. Yeah. So with all these things, it was, I think, being honest and telling that I don't know why this has happened. So many times I use, I don't know why CSF is leaking. I don't know why the pain is not getting better. But we will try. We will keep trying. So that's what maybe that's the only thing that stuck with me was honesty and admitting that I don't know and assurance that I will do whatever the best that I can. I think there's the only 3 things I think I did. I think I did not change the course of the illness or the course of the symptom here. I think that's what it is.
So, yeah,
Naveen,
Savita, yeah, Polo, Savita.
do you think it made a difference that you were the primary physician also?
So
So,
I don't know how others would have. So that's what, no. See, when you reflect back, so many times you feel that whether you did not do the right thing. The self doubt always sets in, and I might have discussed this with many people. Is this the right thing? Is there something else that we could have done? Is there something that I am missing? You feel inadequate. You feel small. You feel that you don't know what you are doing because how can you go wrong on a series? It's like a series that keeps on going wrong and is not getting better. But I don't know, different people would have handled this situation differently, and there are many few cases like that I have seen which had series of failures, and but I think one thing that I think we should do is to be honest always, be upfront and keep reassured and keep trying your best. I think finally people will see the nobility of your heart. That's what I feel more than the outcome.
May
Okay,
I
so then,
ask? Sorry.
yes,
May I
please
ask?
go ahead, doctor.
Um, may I ask whether you have access to neurolytic blocks? Because in this sort of situation, I've seen ganglion impar and those kind of hypogastric blocks, which work very well. Now, I have great deal of problem now with the young anesthetists of getting them done. Nobody wants to kill nerves anymore. But in the old days, my anesthetists used to do these neurolytic blocks for this kind of pain, exactly this kind of pain. The bladder spasms for someone with fairly advanced disease. Of course, you always tell them that there is a possibility of paralysis, with the blocks. But the ones that I've seen done, they have never had those kinds of complications. But the pain relief is miraculous. But because I'm not an interventionist, I cannot do it myself, and it's very difficult to persuade other people to do blocks for you unless you're offered. I mean, obviously you have a chronic pain interventionist working with you. Do they offer neurolytic blocks or even a temporary block to see whether it worked?
No, they did not offer. Yeah.
Mm.
Yeah.
May I ask the interventionists on this panel, would that be something that you do? Ganglion impar block, for example.
Ma'am,
Yes.
Mahesh here. Yes, ma'am. In fact, we'd go with ganglionipar. In fact, in some of our patients, even before going for alcohol neurolysis, because sometimes it's difficult to convince the patient, we give them a local anesthetic block with a low dose of steroids.
With a test first.
Yeah, and it helps in at least a month or so. In fact, I remember a patient with CA cervix, and we've given an inferior hypogastric because she had a node which was causing pain, and that worked very well for her for about 4 months or so, from being in a position where she wasn't able to sit, and it had helped her. And then we did neurolysis for her. So yes, alcohol neurolysis helps, and in selected patients. And I also, from what Naveen sir is mentioning, that taking ownership of the patient. So there is a standing joke that some of the interventionists get to see only the spine of the patient and not the face of the patient, you know. So, so I think it's very important to connect with the patient, and that's where I think Dr. Naveen, he was carrying the cross all by himself, you know. And I feel that the chronic pain, now looking back, I think there should have been a little more sharing of that stress, because it was not his alone to bear, you know. So that's what I feel.
Very
So
true.
let's ask, and there are many more people. What they have learned from this today's this thing. Vidya, Varsha, Vanita, Shiv, Shabnam, Saurav Anand, Dr. Sangmitra, Rupender, Rajesh Mahajan. Anybody wants to? Nilima,
Anjum.
I
Anjum.
want to
I'm
say,
coming from down to up. Monica.
I'm
Yes, please.
Savina. Can I say something?
Yes, please. Yeah. Just
Uh,
want to know, not on the intervention, please. Just what have you learned today? That's what I want to know from everyone.
Yeah, the first thing is that if the going is not going right, then I would have personally thought that we would have, referred to somebody who would have been able to do something more than what we were doing. Instead of just, I would not have kept the patient right with me. I would have definitely asked for help. So that I don't know, because I joined a little late. So I don't know whether Naveen asked for any help, or was there a help possible, is what I wanted to know also. Ki agar if the thing is not going well, then maybe you just don't keep doing it yourself. There has to be somebody who has better expertise, and who can maybe help, maybe over the phone, maybe over mail, maybe some other ways of asking, not only a referral as a physical referral. So I really wanted to know, Naveen, was that not a possibility?
Okay, let me clarify.
So
The chronic
be
pain,
short, Naveen. There are
yeah,
many people have we
yeah,
have to
yeah.
speak. Huh? Just
Uh,
be short.
the chronic
Yeah.
pain team, which was dealing, it was is considered as one of the best in the world. I won't name the physicians. So I sought help from the best team in the world at Adelaide. They are considered godlike chronic pain physicians in the world. So I think we sought help from the best people in the world. Yeah, thank you.
So Nilima and Govindi, would you like to give some comments on today's reflection? That what have you learned? Because now every case you have to be there. One nurse, one doctor will be there from now onwards. So what have you learned today? Who will speak?
uh, Ma'am, Nilima here.
Yeah, yes, Nilima.
Uh, Ma'am, this was a really very interesting case, Dr. Naveen, you have presented. From this case, I have learned is like many times what we tried, whatever best we know or whatever best we have done till now for the patients, but sometimes it's beyond our hand, and from 100 cases, maybe one case we could not do exactly what results we want. So there may we can face such cases also, and we should be prepared for that. And one thing I learned from Dr. Naveen is that we should be communicative during whole the scenario. We should tell the patients that what can I do, what is possible, what can be the positive effects, and if it's not be exactly what we are expecting, it can also be a different way. So we should know how to tell all these things to our patients and their family members also. So this is a very good thing which I have learned. We can share our experiences that so many patients have been get benefited, but we don't know. Sometimes we can tell this that yes, we don't know beyond this, or we cannot do beyond this. That is very good thing which I have learned. Thank you, ma'am. Thank you, Dr. Naveen.
So
Hello, ma'am.
Govindi sister, yeah,
Good
कौन बोलना
good
चाहता है?
evening,
Yeah,
ma'am.
please.
Ma'am, this
Yes,
is
please.
Dipinder. Ma'am, this is Dipinder Kaur.
Yes, please, Dipender, बताओ. हाँ.
Yes, ma'am. We have really learned a lot from this case discussion by Dr. Naveen, sir. And ma'am, I just want to ask one more thing, that the way the sir has presented this case,
can be used in our case reporting as well, ma'am. It is a very good way in which we can actually bridge the gap, what we are doing and what is our vision. And sometimes in our setup, we have some limitations regarding interventions, or we have limitation regarding the setup problems. So, but what is our vision in any case, which we are looking at our institution? By this case reflection, we can really, ma'am, mention all these things. So this is a very good way to communicate, and we have learned a lot from this case discussion, ma'am.
So Dipender, now onwards, in this cohort, we will discuss only this way. So
Okay,
that
ma'am.
will,
हाँ,
ऐसा
this is
होता था ना,
really, ma'am.
जैसे
This
1
is
to
really.
100 पढ़ते थे हम लोग, अब 100 to 1 पढ़ेंगे.
हाँ
So
जी,
it
ma'am. हाँ
is
जी.
always difficult उल्टी गिनती गिनना. So now we will discuss this way only, and I think now anybody so और किसी को कुछ comment करना है?
I
Sister Govindy,
wanted Dr. Anjum's
yeah.
view on this.
Naveen, please, yeah, please.
Yeah,
Tell.
Dr. Anjum's view, because she's also trained.
My goodness. No, Naveen, I think such a difficult case, and hats off to you for staying there and hand holding throughout. And I think the one thing we really need to emphasize is that what you said, honesty, and the fact that we can admit that we don't know the answer. I tried my best. I have done this procedure and it doesn't seem to work, and I do not know the answer. I mean, we often feel that we have to have all the answers, especially that God aura, and we don't have the answers every time. So it's very important that you said. One thing that was bothering me was that you've carried this case with you, like Mahesh said, last 13 years. If somebody, I mean, I hope you're not, I mean, any of us could be traumatized by a very difficult case and have difficulty handling that. So what does one do? Maybe Dr. Cynthia could guide us on what does one do when you have a case which haunts you, that I couldn't handle this properly, or is there something I could have done better, or is this my mistake? Sometimes you take on the burden on yourself. So how does one handle that? Because I think palliative care specialists tend to overextend themselves to help people, and then if that doesn't work, you might end up feeling that you've done harm. So how does one handle oneself?
I think this reflection, the way we're doing it, is very, very helpful. I mean, what spoke to me about what's healing is the commitment. Even though you cannot fix the problems, and this is what palliative care is about, we can't fix problems, but the fact that you're committed to look after this patient, you never left him, that's what's healing. And that's what healing, not only to the patient, but I think it should be healing to ourselves as well. And we should have team members there to tell us that, if we can't tell that to ourselves straight away. And I'm sure Naveen has been reflecting on these 13 years. You know, he's carried it with him, but I don't think it's harmful. But I think as we draw lessons from this, I must commend Naveen to say, you know, the very fact that you saw him every day made all the difference. Even though it's this concept of our going to our patients with empty hands, which we sometimes have to do and maybe some frequently have to do. But it's something we have to learn to do.
So I think anyone else wants to speak? There are
Thank
many
you,
people
Dr.
who
Cynthia. That was very useful.
Kunal here, ma'am. Can I say something?
Yeah.
Yes, please, Kunal. Yeah.
I think everyone is sharing that how difficult it is to manage such a case. I think probably the fact that sir was going and seeing him every day was something making him go. That was probably the only thing for him to look forward to in the morning, that he'll be seeing at least somebody. Despite being in such a situation, at least somebody is coming to at least talk or offer some help. Probably that may be also good thing for the patient. It is so difficult. I think we all see when we are in such a situation, murmuring starts happening near the bed or outside the room, and nobody is willing to go. to face such a situation, or the family. So it is really difficult. I think everyone would have experienced such a thing, and it probably needs, I feel, a total change in our teaching also, because what we are kind of taught in our curriculum, or we are trained, is to do a shikar. For ma'am, like Cynthia ma'am, it is like hunting. You hunt the residents or the SRs when such a case is there. So rather than doing that kind of an exercise, I think if we do kind of a reflective case or a learning kind of exercise, it will be fruitful for everyone.
So now onwards, we will be discussing such cases like this with a difficult, and I think it will be very, very difficult for all of us to find out a case to discuss like this. But truly speaking, this does not happen. This so many times we are we have difficult cases. We think that, oh God, why this things are not going in the right direction, what we want to do, and this will not happen. This will always happen, that it, once in a year at least, when the things will not go in the direction which we want to go. So same thing we will discuss with every centers, every CTC will discuss same way, and this will give you a insight that how successful we are, and how can we find out, because most of the time we have a habit of thinking that what we are doing is correct, and everything we are doing is correct. But sometimes this does not happen. Even in a day we are not doing everything correctly in whole 24 hours, in whole month sometimes we are not doing correctly. And I don't think that Naveen has not done it correctly, but only thing Naveen is feeling, I think Naveen has done a wonderful job with this patient, because putting intrathecal implant is not a bad thing. Putting intrathecal implant is a good intervention. Only he is thinking that why I have done this, because it has given 1 year. For whole of the 1 year, the life was so complicated, and he kept feeling guilty about it, and that's why he remembered this always. And so that's why he, next time whenever he will offer a intrathecal implant, he will think twice about the indication, about the selection of the patient, because all these things are very, very important. And as he said that this was an excellent interventional pain team, so I don't think that was a problem. Only thing, probably selection, or probably the right intervention was, as Dr. Cynthia says, that caudal epidural or caudal block or ganglion impart block. I think we are not going to discuss all these things, but this case has given us uh, a sense that next time onwards we will discuss our cases like this, so that it will give us a something insight, that how can we improve our practice day by day. So this was a fantastic case, and this was a fantastic way of discussion, Naveen. And thank you very much, Seema, and thank you, Naveen,
Thank you, madam.
for presenting first case. And now onwards we will keep discussing, and every time it is going to be a challenge for every team. But don't worry, I think I can enumerate at least in 30 years 30 times, but definitely I will try to find out one case out of 30 that what not went wrong, or what went wrong, and what was not went, because every time the things will not go correctly, but things going is not in the same direction which we want. But you have to follow because things were not going correctly, but Naveen was following for a year. He was taking good time, he was communicating well, and now still he remembers. I think this is the way, this is what the honest practice is. So I think, according to me, you did 70-80% everything right, Naveen. Probably the selection of the patient, probably, I don't know, I was not there, but I think this is what the learning point. Rest everything you did very well.
Thank you, madam. Thank you.
So thank you. It is 8:31. So anybody, Dr. Cynthia, you want to say last comment, anything? Concluding?
No, I think we had a very good discussion. It made all of us uncomfortable, but on the other hand, this is what life is about, and to have the courage to share our failures, I think it really is something. And let's see how the next few sessions run. Thank you.